This is Justine Spargrove, recording Chapter 4, Psychopharmacology. This is for Learning Plan 5 for Nursing Health Promotion. All right, so our objectives are to describe the role of a nurse managing psychotropic medications, explain how psychotropics work in the body, discuss the actions, indications, and implementation and planning that correlates with these pharmacological groups. So anti-anxiety, antidepressants, mood stabilizing agents, antipsychotics, sedative, hypnotics, and ADHD agents. All right, so role of a nurse ethically and legally based on administering psychotropic medications. So laws differ from state to state, but a nurse must understand the ethical and legal implications associated with the use of psychotropic medications. Most states adhere to the client's right to refuse treatment, except in an emergency situation where a client is likely to harm themselves or others. Many states have adopted laws allowing court-ordered outpatient treatment for individuals that have a history of violent or aggressive behavior. All right, so assessment. So a baseline assessment must be applied before a client can be placed on a regimen of psychopharmacological therapy. A history and physical examination, an ethnocultural assessment, and a comprehensive medication assessment are all essential components of this. Psychotropic medication administration and evaluation. So as the nurse is usually in direct contact with a client receiving psychotropic medications, it's important for them to carefully follow directions for administrations and to evaluate the client's response. A nurse should be continuously monitored for side effects, should be continuously monitoring for side effects and adverse reactions and the therapeutic effectiveness of those medications. Client education and psychotropic meds. So the nurse must translate the complex information associated with psychotropic meds into terms that can be easily understood by the client. Clients must understand why the medication has been prescribed, when it should be taken, and what they may expect in terms of side effects and possible adverse reactions. They must know whom to contact when they have a question and when it is important to report to their physician. All right, so neurotransmitters. Neurons communicate through synaptic transmission. Neurotransmitters are stimulated and released to combine with receptors to evoke some sort of response. Small molecules that directly or indirectly control the opening or closing of ion channels. And neurotransmitters either excite or inhibit a response. So some examples are monoamines, so that'd be like dopamine, norepinephrine, serotonin, or cholinergic, which would be acetylcholine, and then amino acids, which would be like our gamma aminobutyric acid or GABA and glutamate are good examples of those. So how do psychotropics work? Or another way to put that is how do psychotropics affect neurotransmission? So most psychotropic medications have their effects at the neuronal synapse, producing changes in the neurotransmitter release and the receptors to which they bind. So we're talking back on the slide before here is we're talking here. We're talking either is going to affect here or here, okay? Neurotransmitters or basically the receptors. Researchers hypothesized that most antidepressants work by blocking the reuptake of neurotransmitters, specifically serotonin and norepinephrine. Now, let's talk about reuptake. This is the process of neurotransmitter inactivation by which the neurotransmitter is reabsorbed and into the presynaptic neuron from which it has been released. So it doesn't go anywhere. Essentially, it gets reabsorbed. So it drops down, but then it gets reabsorbed right away. Okay, that's what we're talking about. Blocking the reuptake process allows more of the neurotransmitter to be available for neuronal transmission. This mechanism of action may also result in undesirable side effects. Antipsychotic medications block dopamine receptors, and some affect muscarinic, cholinergic, histaminergic, and alpha adrenergic receptors. So these are like the atypical or novel antipsychotics that focus primarily on blocking specific serotonin receptors. Benzodiazepines facilitate the transmission of the inhibitory neurotransmitter, GABA, and then psychostimulants work by increasing norepinephrine, serotonin, and dopamine release. All right, so in your picture here, what you're looking at is a picture of my little synapses and antidepressants. So over here on the right-hand side, I describe when normal brain is. So normally serotonin is released, and then serotonin binds to its postsynaptic receptor. So this is post and this is pre. Notice our little pre and post signs here. So serotonin binds to its postsynaptic receptor, and then serotonin binds to its presynaptic receptor. This results in less serotonin being released, resulting in depression symptoms. So if serotonin uptake is blocked, more serotonin is available in the synaptic space to alleviate that depression. Okay, so here is an example of your MAOIs. We have dopamine, norepinephrine, epinephrine, and serotonin here, and we have norepinephrine. They come down here, and the MAO, or basically the monoamine, what is it, monoamine inhibitor, or MAO, basically recycles enzymes such as serotonin or the norepinephrine, things like that. Then the serotonin becomes less active in that area. So then again, it blocks it from being reabsorbed. And then we have MAOIs basically terminate enzymes by stopping the reuptake in the presynaptic cleft or by destruction by the enzyme MAO. So it doesn't allow it to come back up and be recycled, which decreases depression by alleviating those symptoms. And serotonin is important because lack of it leads to depression. So that's why serotonin is so important. We have our SSRIs, which is our selective serotonin reuptake inhibitors. So think about them, they're selective. They don't choose just anything. They're very select. That's how I like to think about them. So here in our presynaptic cleft, they go to our postsynaptic cleft. And here they're more sensitive. And then they're less sensitive in the presynaptic cleft to be recycled. That's why it's important here. So more in the synaptic cleft for the postsynaptic area to use up, and this helps decrease that depression. Then we have our SNRIs, which are serotonin norepinephrine reuptake inhibitors, specifically inhibit the reabsorption of serotonin and norepinephrine, and then elevate mood. Again, more in the synaptic space for the post to use up, decreases the depression. And then our tricyclic antidepressants, or TCAs, inhibit the reuptake of neurotransmitters like norepinephrine and serotonin. And then basically it works in the same process of like the SNRIs. All right, so psychotropic drug effect. So psychotropic drugs can affect neurotransmitters in several ways. There's different ways that they work. They can block the metabolism, block the reuptake, block receptors. They can stimulate autoreceptors or stimulate receptors or stimulate receptor affinity, or they can stimulate the release of a neurotransmitter. So they can work in several different ways. Your picture here shows SSRIs block the reuptake of the serotonin, which decreases the amount present in the synapse and magnifies its effect. All right, here is another picture. This is what I use for benzodiazepines and barbiturates and succinamides and hydantoins and hydantoin-like medications. So essentially, a lot of times it's used for seizures. So I had stop seizures here. So it stimulates the influx of chloride, and that's for benzos and barbiturates, and then delay an influx of sodium and calcium. So that would be the hydantoin and succinamides is how they work. Okay, so here they block that chloride from going through, but it leaves the sodium and the calcium hanging out. So, and then our GABA that's over here is good. It's the natural inhibitory neurotransmitter that depresses the firing of the CNS neurons. So that's why if we have a whole bunch of it, it's actually good because it stops that firing for seizures, so you don't have all those seizures as well. So it's kind of like putting a stopper in, so it funnels through not quite as many chloride, or only allow chloride through. All right, the nursing process, anti-anxiety agents. So let's look at indication, action, and contraindications and precautions for anti-anxiety agents. So anti-anxiety agents are also called anxiolytics and historically referred to as minor tranquilizers. They're used in the treatment of anxiety disorders, anxiety symptoms, acute alcohol withdrawal, skeletal muscle spasms, convulsive disorders, status epilepticus, and preoperative sedation. They are most appropriate for the treatment of acute anxiety states rather than long-term treatment. So it's not supposed to be used long-term, but we do see it used long-term for people. Anti-anxiety drugs depress levels of the CNS. They may increase the effects of powerful inhibitory neurotransmitter GABA in the brain, thereby producing a calming effect. All levels of CNS depression can be affected from mild sedation to hypnosis to coma. And most commonly prescribed anti-anxiety agents are benzodiazepines, including clonazepam, diazepam, and alrazepam. I like to remember those because I say you're not supposed to drink while you're on any of them. So I say don't go drinking with Pam and her lamb. It's a good way to remember Pam and lamb. And Ben for benzodiazepines, Ben dates Pam, and she's got a lamb. All right, interactions for anti-anxiety agents. Increased effects of anti-anxiety agents can occur when taken with alcohol, barbiturates, narcotics, antipsychotics, antidepressants, antihistamines, neuromuscular blocking agents, cimetidine, or disulfiram. Increased effects can also occur with herbal depressants like kava, valerian, lemon, verbena, L-tryptophan, melatonin, and chamomile. And decreased effects can be noted with cigarette smoking and caffeine consumption. All right, so let's go through the proper planning, implementation, and evaluation for anti-anxiety agents. So let's monitor for the following safety issues in the implementation of anti-anxiety agents. So let's monitor for tolerance and physical dependence, drowsiness, confusion and lethargy, increase in effects of the other CNS depressants, aggravation of symptoms, orthostatic hypotension, paradoxical excitement, blood dyscrasias, congenital malformations during the first trimester of pregnancy, and use the following criteria when evaluating the effectiveness of anti-anxiety agents. So look to see if the patient can demonstrate a reduction in anxiety, tension, and restless activity. They may experience no seizure activity, which would be good. Experiences no physical injury. They're able to tolerate usual activities without excessive sedation. They could exhibit no evidence of confusion. They tolerate the medication without gastrointestinal distress. Verbalizes understanding of the need for side effects of and regimen for self-administration, and verbalizes possible consequences of abrupt withdrawal from the medication. All right, so which one of the following medications would be an appropriate PRN medication for an individual with anxiety symptoms? Would it be buspirone, alprazolam, fluoxetine, or sertraline? B, alprazolam. Remember, Ben dates Pam and her lamb. So alprazolam is a benzodiazepine that works as a CNS depressant to produce quick-acting effects of relaxation in an individual with anxiety symptoms. Buspirone has a delayed effect that should not be used on a PRN basis. And then fluoxetine and sertraline may be used as long-term basis with individuals who have anxiety disorders but are not effective on a PRN basis for anxiety symptoms. All right, let's talk about antidepressants, indications and actions. So antidepressants are used mainly for the treatment of major depressive and dysthymic disorders. Some of the newer drugs like the SSRIs have received FDA approval for the treatment of most anxiety disorders, bulimia nervosa, premenstrual dysphoric disorder, borderline personality disorder, obesity, smoking cessation, and alcoholism. Antidepressants work to increase the concentration of norepinephrine, serotonin, and or dopamine in the body. This is accomplished in the brain by blocking the reuptake of these neurotransmitters by the neurons or tricyclic TCAs, heterocyclic selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors, so TCAs, SSRIs, and SNRIs. And there are several groups of antidepressants, including the MAOIs, tricyclic serotonin reuptake inhibitors, the SNRIs, and heterocyclics. All right, so interactions for antidepressants. So there are many significant and dangerous drug interactions with antidepressant medications. For example, antidepressants may interact with drugs such as buspirone or Buspar, TCAs, Celentante, or St. John's wort to cause serotonin syndrome, a potentially fatal syndrome of serotonin overstimulation, or other adverse effects are high fever, convulsion, severe hypertension, or psychosis. And drugs interactions vary very widely depending on the group of antidepressants used. Okay, so these are just a few that you could potentially see as side effects. Planning, implementation, and evaluation for antidepressants. There are several common side effects of an antidepressant that can be managed by the nurse, including dry mouth, sedation, and nausea. So taking the antidepressant with food may be helpful in minimizing that nausea. Some patients take SSRIs or SNRIs may complain of sexual dysfunction. Other side effects or adverse reactions can be very dangerous or even fatal. Nurses must keep up to date on potential side effects. Drug and food interactions have previously been discussed, but important safety issues in nursing interventions for antidepressants are actually on table 4-8 in your book. Indications for mood stabilizing agents. So bipolar disorder is characterized by cycles of depression and manic episodes. Mood stabilizers are drugs that are used to treat this disorder by reducing the roller coaster of the ups and downs, often associated with clients. Lithium was first identified as an anti-manic, but recognized as successful. Basically, it's successful for stabilizing the mood swings of bipolar disorder as well. Depakote or valproate has also been approved by the FDA as a mood stabilizer, and there's been a shift towards this group of anticonvulsant mood stabilizers instead of using the lithium all the time. Indications, actions, and interactions for mood stabilizers. So the exact mechanism of action for lithium really is unknown still at this time, but it's believed to have an impact on neurotransmitters such as serotonin, norepinephrine, glutamate, GABA, and dopamine. Many drugs will either increase or decrease the effectiveness of mood stabilizers. As lithium is a salt, anything that depletes sodium will make more receptor sites available and increase the risk for lithium toxicity. So you want to decrease your salt intake. Proper planning, implementation, and evaluation for mood stabilizers. Clients who respond well to lithium will typically remain on the medication for their entire lives. As such, one of the primary safety issues with lithium is its narrow therapeutic range. It is important to monitor serum lithium levels to ensure they're within the therapeutic range. The usual ranges of therapeutic serum concentrations are different for initiation of treatment in acute manic state and are basically as follows. So for acute mania, 1 to 1.5 would be considered normal. And for a maintenance dose to continuously be on and to be at would be 0.6 to 1.2. Other safety issues in nursing interventions for clients taking mood stabilizers can be found in Table 410 in your book, and it's important to educate the client on these issues. Discourage the client from self-adjusting the medication or discontinue it without a plan in place to minimize that risk, because it could be a huge risk for stopping it abruptly. All right, indications for antipsychotic agents. Antipsychotics are used in the treatment of schizophrenia and other psychotic disorders. Selected agents are used in the treatment of bipolar mania, where others are used as antiemetics, like chlorpromazine, paraphenazine, or prochlorpromazine. In the treatment of intractable hiccups, chlorpromazine is used, and for the control of tics and vocal utterance in Tourette's disorder, haloperidol or pimazide are often used. So the action of the antipsychotics. Typical antipsychotics work by blocking postsynaptic dopamine receptors in the basal ganglia, hypothalamus, limbic system, brainstem, and medulla. They also demonstrate varying affinity for cholinergic, alpha-1 adrenergic, and histaminic receptors. Antipsychotic effects may also be related to inhibition of dopamine-mediated transmission of neuronal impulses in the synapse. Atypical antipsychotics are weaker dopamine receptor antagonists than the conventional antipsychotics, but are more potent antagonists of the serotonin type 2 receptors. They also exhibit antagonism for cholinergic, histaminic, and adrenergic receptors. Indications and actions for sedative hypnotics. So sedative hypnotics are used in the short-term management of various anxiety states and to treat insomnia. Selected agents are used as anticonvulsants and preoperative sedatives to reduce anxiety associated with alcohol withdrawal. Sedative hypnotics cause generalized CNS depression. They may produce tolerance with chronic use and have the potential for psychological or physical dependence. The exception is Remilton or Rosarim, which is not a controlled substance and does not produce tolerance or physical dependence. So let's look at the proper planning, implementation, and evaluation for sedative hypnotics. Many of the same safety issues that arise in implementing care for clients taking anti-anxiety medications overlap with the sedative hypnotics. So there are additional issues to be mindful of for sedatives, including abnormal thinking and behavioral changes such as aggressiveness or hallucinations or suicidal ideation. So when evaluating effectiveness of therapy with an antipsychotic medication, use the following criteria. Can they demonstrate a reduction in anxiety, tension, and restless activity? Do they fall asleep within 30 minutes of taking the medication and remain asleep for 6 to 8 hours without interruption? They're able to participate in usual activities without residual sedation. They experience no physical injury. They exhibit no evidence of confusion. They verbalize understanding of taking the medication on a short-term basis and verbalize the understanding of potential for development of tolerance and dependence with long-term use. All right, so let's look at indications for ADHD agents. So these medications are used primarily to treat ADHD in children and adults. So there are other uses may occur, like amphetamines are also used in the treatment of narcolepsy or exogenous obesity. Bupropion is used in the treatment of major depression and for smoking cessation. Zyban only is the one used there. And then clonidine and guanfacine are used to treat hypertension. Atomoxetine inhibits the reuptake of norepinephrine, and bupropion blocks the neuronal uptake of serotonin, norepinephrine, and dopamine. Clonidine and guanfacine stimulate central alpha adrenergic receptors in the brain, resulting in a reduced sympathetic outflow from the CNS. So the exact mechanism by which these non-stimulant drugs produce the therapeutic effect in ADHD is really unclear. CNS stimulants increase levels of neurotransmitters, probably norepinephrine, dopamine, and serotonin. I'm not exact sure in the CNS. They produce CNS and respiratory stimulation. They dilate pupils, increase motor activity and mental alertness. They diminish sense of fatigue, brighter spirits. Action in the treatment of ADHD is, again, really unclear. However, recent research indicates that their effectiveness in the treatment of hyperactivity disorders is based on the activation of dopamine 4 or D4 receptors in the basal ganglia and the thalamus. Planning and implementation. Clients should use caution when driving or operating heavy machinery. Avoid taking CNS stimulants late in the day to prevent insomnia at night. Don't take any other medications without a physician's approval, including over-the-counter medications. Avoid consumption of large amounts of caffeinated beverages. Report any of the following side effects to the physician immediately: shortness of breath, chest pain, jaw or left arm pain, fainting, seizures, sudden vision changes, weakness, on one side of the body, slurred speech, confusion, itching, dark urine, right upper quadrant pain, yellowing skin or eyes, sore throat, fever, malaise, increased hyperactivity, believing things are not true, and hearing voices. Those are all things that the physician should be notified of. All right, so let's check your understanding. A child is taking guaifenesin for ADHD. Which of the following would be part of the client education associated with the administration of this medication? Do not take foods that contain tyramine. Always use sunblock when spending time outdoors. Report for blood tests once a month. Or do not discontinue the medication abruptly. Answer here is D. Clients taking an alpha agonist should not discontinue therapy abruptly. To do so may result in symptoms of nervousness, agitation, headache, and tremor, and rapid rise in blood pressure. Dosage should be tapered gradually under supervision by the physician. Answer A pertains to MAOIs. Answer B is more specific to tricyclic antidepressants. And answer C pertains to the lithium. All right, so that's it for this PowerPoint show.